Welcome back to both in-person and online folks. I'm going to be handing this over to Dr. Juan Pablo Brito to introduce our next panel.
Everyone. Welcome today. This is the first panel of our meeting, and this is, if I am correct, no, there. This is the first AI panel that we have, and the reason is that with this new technology, very excited but also very concerned about how this technology can support care. I'm JP Brito, endocrinologist at Mayo Clinic, and I will serve both as a moderator as well as a speaker today. Joining me, this is outstanding group of speakers, and you can sit. Are you okay? First, we have Dr. David Toro Tubon, is assistant professor of medicine and endocrinologist in the division of endocrinology. So he's my colleague here. He will give an overview of AI. Then we have Dr. Nike Singh Ospina, an associate professor of medicine and endocrinologist at University of Florida, and she will share her experience as a healthcare delivery researcher and the focusing on how AI can support in cancer research. Then I will talk about role of AI in care. And finally, Dr. Oscar Ponce here is an NIH CR, which is the National Institute of Health Care Research, academic clinical fellow on AI and geriatric medicine in Plymouth Hospital in England. We'll be talking about how AI needs to evolve to support care, and we'll provide one example or one project that we have together about a particular way that AI might be close to measure shared decision making. So with that, we are planning a 60-minute time for presentations. So Casey, if you can help me keeping some track of those 60 minutes, and then we will have 30 minutes for questions and answers in a panel format. That's what the chairs are here for. So to get us started, please stay. Thank you.
Morning, everyone. I'm really happy to be here, and I'm not going to be talking to you for long. It's just going to be probably 10 minutes. I want to give everyone here in the audience a very basic understanding of what artificial intelligence is, what tools we have available right now, so that you can kind of think how is it that this intercepts care and what are the opportunities, pitfalls. So feel free to speak up at any time. If you have any questions about this more kind of like technical side of things, and again, I'm going to try to make it as simple as possible. Always like starting this talk, just getting you back to a couple decades ago when we used to see things on TV that seemed too far away. This was a language robot in Star Wars 30 years ago. And what seemed like science fiction at that time is now something that we're dealing with in a day-to-day. We're all seeing ChatGPT, Gemini, Grok, Claude, Copilot, all of these kind of large language models or softwares that are pretty much that, are applications that are designed to interact with you as a human in a natural language kind of understanding. So this is here, it's already happening. It's actually happening in the background in many other things that we deal with on a day-to-day. When you use your email, when you use watch TV, or when you're seeing ads on the internet, when you're browsing, all of these activities in the background are already embedded with some artificial intelligence. It's just that we didn't used to have that label before, but it's been there and it will continue to be there. And that's why I think it's important to understand what is it that artificial intelligence means. What are these terms? Make it again as simple as possible. So the basic concept of artificial intelligence is this computing technology that is capable to mimic or surpass human intelligence. It's just trying to imitate what we do as humans. Like us, it can process an input to generate an output. The difference is that the machine can actually analyze much more or larger amounts of data. And by doing that, it can actually identify more complex tasks or subtle patterns. So there's a bunch of things that we're going to be probably hearing about. AI, artificial intelligence, ML, machine learning, DL, deep learning, and neural networks, and NLP, natural language processing. And all of these things are kind of related. First one is machine learning. It's kind of like the big circle within AI. this is a subset of AI that is able to learn from processed data. And it can make predictions based on the patterns from that data that has already been processed. So think of it as you have some sort of input, you have humans that are actively looking at that input, extracting features, annotating data from that input, and then we have some systems that classify it to generate an output automatically. There's a lot of human involvement in this kind of machine learning algorithm, the way it is. This is a more simple example. You have some fruits, you have a human that is saying, okay, this is a banana, this is the shape of the banana, this is the color of the banana. And then you have a classification system in which the machine pretty much just follows these patterns or this classification based on what it learned from the features that were extracted by the humans. We have a more advanced system, which is called deep learning. This is inside of machine learning. And this system is actually able to analyze data more automatically. And it does so by taking raw data that has not been necessarily pre-processed by a human. It works through something called neural networks. And these neural networks, think of it as the human neuron connections. It's a bunch of interconnections between different features. So what the system does in this case is it takes an input, it automatically makes a lot of connections between the features that the system automatically identified. And based on all of those connections and combinations, it gives you a prediction, gives you an output. So this is kind of how it works. In this case, you're just giving it a bunch of fruits. You're just telling the system, this is an apple, this is an orange, this is a banana. But you're not really saying, this is an apple because of this is a banana because of this. You're just telling the machine what you're giving. And then the machine is able to automatically predict, okay, based on what I learned from what I understood from each image, this is a banana, this is an apple, this is an orange. So it's much more automated. The challenge that we have in healthcare is that all of this sounds beautiful, but the way we use data in healthcare, it's actually very complicated. We don't have just bananas, apples, and oranges. We have a computer system that actually is just a layer that connects the health records, the radiology records, the laboratory records, pharmacy records, administrative records, and all of these things are kind of disconnected. So one of the technologies that it's affecting us most right now is actually that. How do we use that data in healthcare? And because of the structure, most of this data, because it's so fractionated, has to be a structure in the sense to be able to communicate. So it has to be codes, ICD codes, or it has to be pharmacy codes or procedural codes. These corresponds to a very large amount of data in the records. But problem is, for us, those codes mean barely anything, right? We have a lot of unstructured data that we actually spend a lot of time on. Assessment and plans, physical exams, history of present illness that are kind of stored in a system, but are not readily accessible to us or to these models necessarily. Because again, they're not structured, they're not designed to connect to each other. So from all this data we have, 80% is unstructured. We cannot really use it right away. 20% is structured. That's the one that is used for like big data right now. So for that, we have this additional technology called natural language processing, which is an intersection between linguistics and artificial intelligence. And the goal is to be able to retrieve this data that is unstructured, whether that's text or that voice or that's video, and automatically process it so that it can be readable to a machine, so that these machine learning, deep learning algorithms can actually use it to help us. So think of it as kind of translating. Takes unstructured data, translates it into structured data. Now, again, all of this has been here for a long time, but what has made the difference is the newer technology, which is not only able to kind of analyze this data, but also generate something kind of new from this data. And this is what is called generative AI and what has happened with all of these ChatGPT and all these other ones. And this is just very simple the way it works. In traditional natural language processing, the way it works is you take your data that you have cleaned, that you have processed, you feed it into a platform that is going to analyze and learn from that data. And then that platform is going to give you an output. and then the process goes over and over again, and that's how the system learns. This is the traditional way. The newer way, the generative, we have these systems called large language models, and these are, think of it as kind of systems that have just been trained on a lot of data in the world. It's not your data, it's not the data that you curated, it's just data outside in the world. Very large amounts of data. And what these systems do is they learn how to predict with mathematics the probability of a sequence of words happening within a corpus of text. So think of it as like fill in the blank. Very sophisticated systems that fill in the blank based on probabilities. And that's the way they try to understand language. I know this sounds very complex, but wait for the example, it sound easier. So you have these models that were not trained in your data, and then you're applying them to your data. So your data doesn't come until a couple of layers. And the way you interact, these interacts with your data, it's based on questions, based on prompts that you're gonna do through the system so that the system can go and review and analyze that text. So this is an example. In traditional natural language processing, you have a clinical node. And this clinical node is gonna go through a platform. The platform is gonna have a dictionary that you have already preset. You as the clinician or the investigator have said, you know, symptoms are this, medical conditions are this, a list. And the system is gonna go and read through the notes and identify those concepts that you already have predetermined when you were training the system. And based on that, the system is gonna tell you, for instance, this patient maybe has Graves' disease. Okay, so very simple. It kind of follows the instructions that you have given to the system. The large language models are a bit more complex. This is the exact same node, but what we're doing here is we're applying it to the large language model that was trained in unrelated data. And you're telling it, you know, tell me who's Mr. Smith, if there's any family history, if there's any symptoms that could be from thyroid disease. And based on these questions and what the system has learned from other data, the system is gonna come and say, okay, Mr. Smith is a patient, he has a family history of Graves' disease, and he's experiencing symptoms that could be from Graves' disease. And on top of that, it could automatically give you, this is my history assessment proposed plan for this patient. So it's a next step. Now this looks beautiful and this has a lot of potential. That's why we're listening about it every day, everywhere. There's potential to influence clinical care, research, medical education. And there's a lot of promises that you're gonna see around. So you're gonna be hearing about predictive models, facilitating more and personalized diagnosis and treatment. You're gonna hear about improving accuracy and consistency of diagnosis. You're gonna hear about improving access to a specialized care, especially in areas where maybe you don't have those expert resources. You're gonna have accelerating the learning curve of less experienced providers, assisting in scientific publication, facilitating data extraction for clinical care and research, deepen our understanding of pathology, diagnosis, prognosis, therapy, assisting with clinical documentation, automating and streamlining administrative tasks, improving patient communication, and there's many, many more applications to come. But what I want you to keep in mind throughout the rest of the day and in the months to come is there's a hype for AI. Again, we're hearing it absolutely everywhere. And when you take a look at the curve that we have on the screen, we're not even at the peak of the hype. What happens with these hypes is that after the peak, you go into this very steep slope of disillusionment. And there's gonna be a long way before we can actually go from where we are now to be able to use these things clinically to help our patients. And this is probably gonna take many, many years. But I do think there's a responsibility for us to be at the center of it so that we can use it accordingly to provide care. And that's what the rest of this panel today is going to be. How can we harness the potential of AI and all of these tools to actually provide care? So with that, I'll give word to the next speaker.
Right. Well, good morning, everyone. First, I want to start by saying that I'm very grateful for the opportunity to be here and discuss with you a little bit about artificial intelligence and care that fits. But more importantly, for the opportunity to spend time with many friends and colleagues. Based on just kind of like the day I had yesterday, I was thinking that I think of myself more of like a care unit alumni, more of like a care unit expat, because the care unit felt more like home than just like a place that I did training. But I will add that it was a very cold home. So with that in mind, now I'm living in Florida, so things are a little bit different. Uh, artificial intelligence here. All right. So I don't have any conflict of interest as they will relate to this topic. And as I mentioned, my goal is really to discuss the potential of AI to improve encounter research, but kind of like situating encounter research within the work. And as I mentioned, as a care unit expat, I'm thinking that what I try to do mostly now is to provide careful and kind care for my patients, but also help others receive and provide careful and kind care. What happens is that up to today, I would say that this feels like impossible problems or an impossible problem to tackle. And I don't think it has anything to do with us or kind of like the work we do. It's just how kind of like the problem is, just inherent complexity of the problem. And a way of thinking about it is that I know here we have focused a lot on the clinical encounter, and that's part of the goal of this talk. And we think of the clinical encounter as this place, like this epicenter of care, where very important decisions are made that affect the life of patients and so forth. But really, when you think on a kind of like take a step back, patients or clinicians are living their lives outside the encounters, and they have competing interests and things that they have to do. And that already makes it an impossible problem to fix. But then, as was alluded earlier this morning, with the question about access and equity and all these things, well, all these interactions are also happening within a healthcare system and within societies that not necessarily have careful and kind care as their main goal. So to talk a little bit more, to give you some examples about how AI can then help us solve these impossible problems, I'm going to reflect on two personal experiences as a health service researcher. One, some work that we did trying to understand the diagnostic process and how we could do diagnosis better. And then second, some of the work that we have done to develop and test a conversation aid for patients with thyroid nodules. So let's talk for the first example. So if we think of the problem as diagnostic errors and the current ecosystem of data that we have, or the research method that we have, as David already alluded to, we have information that comes from the EHR, from large data sets, but also we can get input directly from patients or groups of interest as patients, clinicians, and so forth through qualitative research and mixed methods. And with that, we are overall able to understand the problems to a certain degree. In the case of diagnostic errors, we know that they are very common, that they can be very harmful for patients. We also know that certain patients and certain diagnoses are more likely to have and lead to diagnostic errors. And then we know that there are some things that increase the risk and some things that we can do to mitigate the risk of diagnostic errors. In fact, this is how the National Academy of Medicine thinks of the diagnostic process. And you can see here on the left that it starts with this, the patient experience a symptom. And then it engages with the healthcare system. And at least in this figure, that's where everything else kind of like happens. So it goes with this idea that the clinical encounters are to a certain extent the epicenter of care. But as I mentioned, that's just kind of like with a caveat, because all of this is occurring on the background of the healthcare system and the society. So when you think that way, you're thinking, okay, we're probably going to have a lot of information that help us understand what actually happens in the encounter where a patient comes with the symptoms and is trying to reach a diagnosis. And when we try to tackle these questions about what are diagnostic conversations in practice, we conducted this systematic review. And as you can see there, we only found 7 papers that actually had encounter research for the diagnostic process. Most of these were single center studies, and they were relatively small. Suggesting that although conceptually we think that what happens in the encounter is important, we are not really informing our understanding and potential solutions of the problem using that data. Now, even though we only had 7 studies, and then as I said, not that many clinical visits, when we did our analysis, and this was mostly qualitative analysis, we found some information that I would say is insightful in terms of what is happening in these conversations. So as you can see here, we noticed that conversations between patients and clinicians included some activities that can support or actually hinder the accuracy of diagnosis. So how the patients were framing their questions and framing their problems actually impacted what will happen afterwards. How patients and clinicians were discussing when a patient had multiple symptoms or multiple things going on, which one to address first, and then also how they talked about the uncertainty of the diagnostic process as a whole. So definitely insightful information that can help us understand these complex problems that we're dealing with. So far then, I hope that I kind of like convinced you that probably encounter research is underutilized, but is helpful based on this personal experience with the diagnostic process. But there's some other work from the group showcase here that looked at kind of like videographic or clinical encounter evaluations across all potential diseases in the outpatient setting. And you can see that, there were more studies, obviously, because the scope was broader, but also a general small number of patients or clinical observations that are being analyzed. And that obviously decreases the generalizability of the findings or how much patterns or information we can find there. And then the other kind of like interesting finding from this study is that it does seem that through the years, the number of publications that included encounter research was increasing. So again, hopefully I have convinced you that probably the clinical encounter is very important, but that so far, as we're trying to achieve or reach careful and kind care, is a little bit of a black box, but probably it will have a lot of information that help us understand problems. And as I'm gonna shift now, also understand what happens when we introduce an intervention that is supposed to affect conversations, so that then we can actually measure or see what is happening as a result of the intervention. And the other then logical question is, well, if this encounter research is so good and we should be doing it, then why are people not necessarily doing that much? And one, it could be that they don't share these values that I have just discussed, that the clinical encounter is the epicenter of care, which is valid. And then the other might be that even if you do agree with these principles, then maybe there's some difficult logistics for obtaining the data. So you have to record the encounters. There might be concerns about privacy, need for the structure to kind of like save this with enough protections. And then you have to analyze all this data, and this will be very time consuming, and you need a lot of training to be able to do this correctly. So it can be costly, and then probably this could contribute to why this is not scaled up, if you believe the assumption that clinical encounter research is beneficial. So again, kind of like impossible problems that we have chosen to address. Can AI help us do this better? And as I mentioned, so I live now at in Gainesville, which is known as the swamp. And then everything related to the university is related to gators. In fact, the large language model that we have at the university that was trained with data from kind of like the UF network is called Gatortron. So I'm not exaggerating. So everything is gator related. So then I think that had permeated into me. So when I was thinking of the presentation, this is how I'm kind of like envisioning AI in the future as a gator. All right. Now this, I think, is the conclusion, kind of like a spoiler, like the conclusion of my talk here, is that I think AI is an amazing tool and is going to be able to help us open many doors. In this case, for example, what is happening in the encounter. But I also think that it's not going to help us open every door. And as David mentioned, it's not going to help us open the door today as we're having this discussion. And as you can see here on the example, you have the remote that will work to open the car. But if you use that remote to open your house, it's probably not going to work. And I use this example because this happens to me on a regular basis when I come home from work. All right. So now I shift to kind of like the second story of how this kind of like made sense, which is the work that we have done to develop a tool to support shared decision-making for patients with thyroid nodules. And we have here a mock-up of what that tool looks like. Focuses a lot on trying to understand what is the risk of the patient for having cancer, so that once we understand that, we can see if we need to do a biopsy or do surveillance as the next step. So as I was kind of like preparing this presentation, then I had like this mental exercise of, okay, we have been working on this tool for the last couple of years. If I were to be working on the development and testing of this tool, then 5 years from now, or 10 years from now, or 15 years from now, depending on how pessimistic or not you are on how fast technology is gonna develop, then how would it be different to what I kind of like did right now, or that what we have done so far? And to explain that, I'm using kind of like this framework that we have used before, and is probably familiar for many of you, of how we go through that process of developing the tool and testing it. And this is from work that we conducted with JP a few years ago, many years ago now, 2015. That it was a tool for decision-making related to options for patients with grave disease in terms of treatment. And again, spoiler alert, I'm gonna go like step by step, kind of like highlighting where AI will help, but it's basically like the whole screen is gonna be blue because it potentially can help in each of the steps that we're doing. So the first one is the evidence synthesis. Of course, our tools are all evidence-based, and as the one for thyroid nodules is we did an evidence synthesis to understand how do we calculate the risk that the person actually is gonna have thyroid cancer. How might that look in the future? Again, there's already preliminary evidence and kind of like some pilot data that shows that we can teach machines with some of the methods that David had discussed to screen the abstracts and the papers, to extract the data for us. And again, if you give them the rules, to even assess the risk of bias. Can we do that today? No, but again, definitely something possible in the future. Then we go to that second spot, which is, okay, we need to create a prototype. So based on the conversations that are happening in practice, what questions patients are having, what things are difficult to communicate in the encounter, to kind of like create a prototype that we test in practice. And again, if you have a large language model that has been trained and given information from patients, clinicians, and also from researchers in shared decision-making, AI can serve as another member in that discussion on creation of that prototype. And then there are some other forms in which people are using the large language models to kind of like in a faster way summarize concerns that are brought up during forums discussions online, or the questions that, let's say for thyroid nodules, somebody goes to Google and says, do I need a biopsy? When should I consider a biopsy? What are the risks? So kind of like summarizing some of that. And again, it's not gonna replace, I think, the current process that I show, but it could potentially make it better or faster. Then, as you see, the next is basically the second half, which has to do with all the evaluation, conducting that clinical trial to see if the tool is helpful or not. And again, it's all highlighted because there's already preliminary data that you can train the tool to identify patients that have thyroid nodules and have not had a biopsy. So very simple criteria. You could use chat box to help answer questions during the consent process. You can give a bunch of data and ask it to generate a report for the IRB. Somebody will have to review it, but you will have a first draft. And then it can extract data. And then in terms of analysis, I like to say, it's just like the most fanciest of all the statistics, right? So maybe the inferences will be a little bit better. So again, a lot of promises there. And then going back to my initial discussion, which is the clinical encounter. As I mentioned, this is what we have on one side, where all the problems that we're having, all of the barriers that we have to kind of like use clinical encounter data more routinely. And then this is how potentially AI could alleviate some of those barriers or mitigate some of those. So I think for the first one of the logistics of obtaining the data, it is very, very possible that the recordings of clinical visits might just be routine in the future. It will be like when you go and get your vitals checked. So it's just part of the practice. And you can see like in many places where AI-based scribes are being used, where those conversations are already being recorded as part of practice. The second is the analysis of data. And I think here, Oscar might start showing some data of what is possible or not. But it could automate a lot of the processes. It can help us integrate a lot of data and identify new patterns, as was already discussed. And then at the end of the day, the idea is that this will be faster, less expensive, and then we won't have studies on 50 patients in a single center, but a more large and diverse data set that can probably strengthen our inferences about what is happening in the encounters, because we just have a bigger volume of data and make it more generalizable. But then also evaluate other aspects in kind of like this scale-up version. So nonverbal communication, tone of the voice, how people stop or pauses, and things like that right now are helpful, but will take forever to do for 2,000 patients or 5,000 patients. And again, now going to kind of like maybe in a circular way. So I kind of like make the assumption that the clinical encounter is the epicenter of care and is the most important. and that this is kind of like what we have right now. Some of the problems that we are trying to address, things of like overuse or over testing, but then on the other side, when there's underuse or under testing of conditions, or when we're trying to understand how the introduction of EHR to the medical record, or even how the introduction of AI scribes change the interactions and so forth, we can have kind of like a reasonable understanding of those problems today from data, as I mentioned, from the EHR, from claims, or from qualitative or mixed method data. So we have some understanding of those processes. So what I'm kind of like talking here is a kind of like adding one more layer of understanding to the problems we're trying to solve in a more efficient way with the use of AI. So then we might be having this same table, but with all this additional information that we got from the encounter research. But, you know, as I kind of like think of it, I'm not hesitant that the technology will get there, in which all of these things that I mentioned are probably going to be possible. I don't know the time frame, but I think that part, I'm more convinced that it will happen. Like the tools will be developed and we'll be able to achieve those outcomes. What I'm kind of like philosophical, more kind of like unsure, is that whether, as I show you there in the table, whether the encounter research data is going to be incremental knowledge that maybe will have limited impact on care, or it might be the opposite, might just kind of like revolutionize everything that we have. So I'm not that, I think the technology is going to be there, but the actual outcomes from the clinical encounter data, I'm not so sure. And one part of that is that I think it might be confirmation of what we already know. Like we kind of like know what those conversations might already be looking like, which is that patients are not necessarily, that in that space, people are not noticing the problems and are not addressing them. So really, we're just kind of like confirmation of that, not necessarily new insights. But the part that it might be helpful is then when we introduce tools to change that, then we can then measure that change. All right, then, as you can see here, this slide, basically everything could potentially be improved by AI, but it's nothing that we can necessarily use today on our day-to-day practice already. And then I just have two more points that I want to make before I pass it to JP. So one is many times when people see this, there's this potential fear of replacement. I personally don't think that that replacement will happen, at least in my lifetime. And I think a lot of these things will always kind of like seem to require a human to be on the loop. And then on a very personal note, I'm not really afraid or have fear of replacement, because if I could retire today, I will actually like it. So I don't have that particular concern. And then the second, which I think goes to the point that probably you're going to hear through our talks, is that these are all kind of like promises. And I presume that all of us in our lives have had some unfulfilled promises. But as David said, I think this work needs to be done. And we have kind of like this other commitment with careful and kind care. So having us being in that space is very important. So thank you.
Thank you, Michael, and thank you, everyone. Here, let me just try to bring my slides. I can pass with this though. Thank you again. As I said before, I will be talking about the role of AI in care. David and Nike, wonderful presentations. They provided some insights on how these tools actually work and potential uses. So they can do all those wonderful tasks, predictive and generative AI. They can translate, they can summarize. They're very good at questions and answering. They can classify texts, they can predict events, they can predict conditions and so forth. But in the unit, we have been trying to, in the care unit, in a group, we're trying to make sense of this. And how does these tools, hundreds of tools and hundreds of papers being published every month, actually make sense to take care of our patients? And when I think about care here, where I'm trying to focus is in that space, in that conversation in which patients and clinicians are working together to find out how to address a problem. So that is care definition for the benefit of this talk. And to trying to map the roles of AI in care, I'm borrowing from the work of Ian Hargreaves in terms of components. in that co-creation of a plan between patients and clinicians, starting with the component of noticing that there is a problem that needs to be addressed, a component that has to be clear for both, formulating ideas how to address the problem, trying down those ideas and see how that affects the patient's lives and how actually affects or addresses the problem, forming a conclusion, a plan that makes sense, not only intellectually, but actually practically and emotionally to the patients and clinicians. And finally, implementing this in the patient's lives. So the way that we think in the unit at this moment, which is work in progress, is that there might be three roles of AI in care. Thinking about two potential axes, 0 to potential domains, the complexity of AI, and the time and how these AI systems will evolve. And starting from the bottom, we have the care assistant role, in which represented as AI, I wish I have the lizard, I think it's better, the small lizard, but the robot is outside of the point of care. So it's not really affecting the point of care, the conversation, but it's helping to some extent, but intervene before and after. That is mostly the care assistant role of AI. But eventually, we can have a care augmented role of AI, in which the robot, the software, the algorithm might intervene in that conversation, in that interaction. And maybe in the future, we have a role in which care replacement, in which the clinicians will not longer be needed because the robots might be replacing us. Thinking about some examples of care assistant AI, this is again, the algorithm, the software helping before. From the clinician perspective, is the most important thing, and for the patient perspective is to work in noticing. So how the AI system can help patients and clinicians notice the problem is for them to be ready, to be mindful, to be focused. So clinicians, we are completely overwhelmed with a bunch of administrative work, prescriptions, paperwork, things that we need to prepare even before we see the patient. And when we see the patient, what is in our minds is what I needed to do before I get to see you. And you're actually using my time because I have 2 hours of paperwork that I need to complete. So what if AI is actually there to remove the noise before the encounter and help us be mindful and help us to focus on that? What if instead of reading 100 notes to make sure that I understand what the patient is coming, what is the problem, I have a nice summary, not only in the biology of the patient, why it might be related to a lab value, but also from the biographical component of the patient. What makes the patient actually enjoy life? From the patient perspective, in a similar way, to be ready to help the clinicians notice the problem. Patients do a lot of work in getting to see us first. They need to think about access, they need to think about insurance, the premiums, they need to get the approvals, the in-network. A lot of work to get us in that room. And all of that work actually distracting. And what if we help the patients remove all of that and prioritize the questions and concerns that they have before we see them? So both can see them and notice the problem. After the encounter, AI can assist by implementing what they have decided. So all the components of the conversation, implementing will be the one in which care assistant will be after the encounter. So what happens is that the doctor, instead of spending time typing, it will be automatic transcription of that into the notes. How can we do better? How AI systems can actually help me do better work if I get the feedback on how I did? And questions and answers that I can be able to AI systems to at least give me some drafts. So when the patients have questions and answers after they left, I don't have to go back to the chart and understand what happens, but some degree of help there because we spend a lot of time answering questions after patients leaves. From the patient perspective, I'm always surprised and amazed that always, as many clinicians look at the screen of the computers as patients talk, patients are actually looking at their pads, writing down what the clinician is saying. So the clinician looks at the iPad or the clinician looks at the computer, the patients are looking to the paper, writing down what is happening because there are so many things that they need to take notes. They need, what the doctor is saying, what is the medicine, what is the name of that medicine, what is the dose, when I should come back. So why we develop a system in which the patients have access to the healthcare records in a way that they can make sense to them? Clear language, easy language, summarization tasks, something that AI systems could do now. And in order to help them, so the doctor prescribed you this medicine that if you get to go to Costco, it's actually $20 cheaper than if you go to CVS. Or what if the AI system tell us that you are already set up for an appointment in 2 months, and you don't have to call anybody to do that? Care augmented is an instance in which AI might actually intervene in the point of care. But for me, it would be fantastic if it is actually silent. It doesn't say anything. It's just let the human beings interact. So the most important promise of AI is that it disappears. That it disappears taking the computer with them. That it will be 2 chairs with a table. And just let the humans be. What if that is the dream, as we had it probably decades ago? But similar to the automatic, the self-driving cars, I think there is some use of AI here, which, when you're driving your car and you're gonna cross the line, that there is a light there that says if you cross it, you're gonna hit the car. It might be something like that in which you are in control with the conversation, but you are missing a signal that the patient might have other problems. And the AI system might tell you, this patient might have a stroke. Or you are missing an important factor here. The patient is under distress. So there might be some use of AI here that put us in the right path. Or it can help us with simple tasks as just translating things. Clinicians here in the room and patients in the room, you might know how difficult it is to use interpreters and how we feel that those encounters are not as good as when we speak the same language. So what if they just help a simple task of translating in a way that makes sense also even culturally? Another things highlighted by Naki, for instance, diagnostic errors or even decision support systems. And all those things will be helping in all the majority components here of working together to find a plan that makes sense, noticing, formulating, trying out, and forming a conclusion. But I told you that AI can replace us. But it's hard. I mean, I don't see it how. I mean, even I put it there, and we have discussed it as a group. My definition of care included 2 human beings. So how come we're talking about replacement? And I have a very difficult time with this, but of course the field is not having a very difficult time. We see papers all the time suggesting that we are gonna be replaced. So 2 papers here in the top. In the top is a paper in which they ask patients to recognize whether their answers came from a robot or came from a human. They were blinded by it. And then they told them, by the way, your answer was from robot or your answer was for human. That was healthcare related questions. Patients consistently couldn't differentiate between humans' answers and robot answers. And in the bottom, similar thing, but in this study, they actually assess the quality of the response and the empathy. And as you can see in the graphic, the ones by the chatbot AI system was graded much better in quality and graded much better in empathy. Suggesting, of course, that they are getting to the point that it might be better than the clinicians. You can see a myriad of apps right now that replace psychiatrists, or that this is personally offended by this, they can replace endocrinologists. So they take the patient from the start, they take it for the symptoms, they give you a prescription, and they give you a follow-up. It's a platform dedicated to replace 3 of the 4 speakers today. And probably this is what the field has reached as the closest to an idea of replacement. It's a system called conversationalist or conversational diagnostic AI, developed by Google. And they developed a system called the AMI system, in which they were trained with different sources of data, questions and answers, typical medical questions, encounter data. And they have some fake cases with fake patients. And then these patients learn the case. And then they have a chatbot kind of interaction with either a human, actual PCP, a primary care physician, or the system. And the patient consistently graded the interaction with the chatbot AI much, much better in 26 domains of quality of the interaction, 24 of the 26, sorry. Suggesting again that they might be better at hearing, maybe better in engaging, maybe better at communicating things. But this beautiful thing from Twitter, I think summarizes how I feel about it. So the AI company says, we trained this dog to talk. It doesn't actually understand language, but it kind of sounds like having a conversation by mimicking the sound of human speech. And the field and the CEO suddenly says, awesome, I will fire my entire staff. How quickly can I start diagnosing medical conditions? So this is actually what's happening. So is this a problem of just because the AI is limited right now? I don't think so. I don't think so because numbers don't care. These are numbers. These are vectors of numbers aligned in a way that create an app. People actually. But when we think about what actually makes care unique, why robots might not be able to replace us and help you with your goals of being out of the job in right now, we have been trying to say, what is things that even future AI, even the most advanced AI, might have some issues in replacing us. And reflecting on the care that I provide to patients with thyroid and thyroid cancer, we as a group, we have been exploring a few of them. And one of those things is that understanding, the noticing, is experiential, which means I'm borrowed from my life experiences to understand when a patient has pain. Pain is not a number, but something that I can relate to because I have suffered pain. The machine will never understand. They may not be able to borrow the life experience of experiencing pain. This is actually cases that happened to me. So my patient with thyroid cancer has been doing very well for the last 3 years and is nearly ready to be discharged. So I went there and say, excellent, you're doing great. I think we might not be able to see you again. And she started crying. Was she crying because she thought that she was getting sick? Or do you think she was crying because we developed a relationship for the last 3 years and she's gonna miss me? So it's the latter. But the machine will never get this. We'll have some difficulty getting this. And I think the machines will have an issue of acting when there's no data, or choosing not to act when the data even is available. So these are systems that are training data. What happens when we don't have that data? Or what happens when we have very good data and the best course of action is actually doing nothing against that data? So I have this patient that was advised several times by 3 other clinicians that they need surgery for his thyroid cancer. I was the 4th one. And when we discussed this, we decided not to do anything because actually his wife had dementia and he valued the life of his wife much higher than his own life. And we have to make that tough decision. Do you think machines would understand that? This is something that borrowed from Ian, that he says that the caring process actually changes, reshape us. And it's true. And I think clinicians can relate to this. Patient with advanced thyroid cancer decides not to pursue any medical intervention, but rather prefers to travel and spend time with his family. When I get home, I have my kids because that experience changed me as an individual. So he decided not to receive any treatment for thyroid cancer, to spend time with a loved one. When you go home, you want to spend time with the loved ones. There is something else that happened in that encounter, has nothing to do with data, that changed me and likely changed my approach even with future patients. And I believe, and again, reflecting on this, is that there is a lot of investment and effort beyond an outcome. When you really care for someone, you don't take shortcuts, you do more. And the machine, remember, it will be efficient. It will get to the outcome, whatever that is trained to achieve, in the shortest way, in the most efficient way, saving money and saving time, saving computing power. As long as the outcome is the same, it will take the shortest shortcuts. And it's clear when it was a patient that was very young, it was 19, again, thyroid nodule. And I remember that somehow I thought that she might look like my daughter. And I was checking on her, say, are you doing fine? And I was calling just to make sure that the biopsy went well, make sure that she's okay with the pain. That extra effort did not really have other than me caring more than when I should have cared. There was something else behind that. The effort that I put on caring for the patient, it was not needed, but it's something I had to do. And I think the machines will have issues with that too. So, will ever be replaced? Is that for sure a no? And I think there might be some room. And this is borrowed from Victor, and he describes the nature of those clinical encounters and those conversations, that they are not always that complicated. It's not always about patients with thyroid cancer that decide not to have treatment. Sometimes it's the infection in the nail, it's the fracture, it's a very typical thing that we can do to fix a problem. And perhaps if we call that fixing of cure on the extreme, and the more complicated kind of care on the other extreme, with some a little bit overlapping, there might be a little bit of a role in AI on that. So more care assistant and augmented in the instances in which we need a human, because it's a complicated conversation. And in the fixing part of things, we can get replaced. We can get replaced. If you have a very good system to identify the infection in your nail, why do you need to go to all those things of, making sense of the problem? No, it's an infection of the nail. I need it to be fixed. So there might be some roles of that, as long as we understand that there are situations that merit a human and situations that deserve probably more fixing and access and to entity that help us fix problems. In this situation, however, we need to think about the ethical concerns as well. As we move forward for an assisting augmented replacement, the concerns about the ethical concerns continue to increase. So the typical concerns, data security, privacy, data ownership, and those kind of things are alleviated to some extent because assisting always have a human there. Even in the augmented component, although in the augmented component, we can fall into what is called automation bias, meaning that I will trust what the beep is alerting me against rather than my own judgment, meaning that in other words, if you are driving a car and says, you have car there, I will not cross it even I don't see it. So I'm getting used to this automation so much that is replacing my own judgment. And of course, in replacement, all those things get magnified because there is no human involved. So we're using this as a map, and you will see a lot of examples of how we're thinking about AI and care with Oscar following me, and the presentations in the breakout sessions, many things that we're doing in care assisting more than anything else. And we have tried to use this to put and map them where they're gonna be in terms of the role of care. And we have created within the care unit, the Care and AI Laboratory, which a group of people, the majority here in this group, that is trying to make sense of this, trying to develop those technologies, always keeping an eye on how much they will improve our care process. And thank you. Doctor, okay. All right. So we have Oscar, and then we will have questions and the panel.
This one's you, Oscar, right? Okay.
All right, the bar is very high. So I don't know what I'm gonna be saying now. So David has spoken, I'm Oscar, sorry. So I'm gonna be speaking about the transformation of AI. David has spoken about what AI is, what are the tools and everything. Nike has set some examples of how we can use AI, and JP has talked about the future. So probably you went too far to 2080 or 90. I'm gonna pull you back to the present a little bit and tell you a little bit about myself. I did medicine in Peru, but then came here, learned a lot from Casey, Ian, JP, and Victor, and the others who were here before. I then went to do kind of a computer science degree in Edinburgh. Forgot about medicine, didn't touch any medical thing, not even like AI healthcare. That didn't happen. That was purely computer science. During that time, I was like, what makes me unique? Like, I mean, these guys here have been coding their whole lives. Um, so what I did was like, okay, I've learned a lot from the care unit. Well, at least that's what I think I did. So what I did was read their papers. I read Casey's papers. I read JP's, Ian's, and Victor's. Too many Victors. So, but I tried to read, and then I opened his book for the second time. So yeah, and I think I thought, okay, this is what I can bring to the table. This is what can make me unique. We should see AI not from, if you see the title, I'm not saying AI is gonna transform your life. What I'm saying is how can we transform the way we see AI so that it can fit our purpose? So can we transform how we do AI, how we build the model, how we do the implementation or whatever comes with doing AI so that it can fit the purpose of care? So this is what we're trying. So I'm just gonna explain to you a little bit what our thoughts are as a group or as an individual. So what happened here? Okay. 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 Not conflicts of interest to disclose, but I do have some cognitive disclosures. I don't know if that's the right way to say it, but um, artificial intelligence is not really intelligent, so it's just a term. You put it there on the grants because we want money. We put it there on the papers because it's catchy, but just is not intelligent. So you can change it. You can change the term to other names, like it's just a word that summarizes a group of methodologies. And actually, when I did my master's, I probably can count with my hand how many times we use the term AI. We never used it because what we use is what are the methodologies behind it so that we can understand it, right? So this is a very important part for me, at least. But I do understand speaking about AI is quite easier because you say AI, everybody is like, oh, there's a fancy thing happening behind. But it's not a person thinking, so it's not intelligent. So let's talk a little bit about common AI tasks and how is that being here, being like kind of changed or transformed by the care unit helped me in finding this or help us with JP and collaborating and trying to do the work that we're doing. Even though Victor rejected me at first. And I love telling the story because I emailed Victor, I'm gonna vent, sorry. So the first thing that I did was for my master's thesis, I wanted to do a cool study. So I emailed Victor, was like, Victor, I have this cool idea, whatever. And I've always heard Victor saying, you have to be unique, you have to think outside the box, right? So I emailed Victor, I was like, Victor, I want to do this. And he's like, long email saying, in conclusion, no. It felt like, oh, there are like these like 10 challenges. I don't know if you can make it, sure you can do it, but it's just a very, very, very generous and kind no. But I felt like, as Paul Barth, I think, said, Victor was like saying, no, not too much out of the box, come back to the box. But anyway, so JP was kindly actually accepted talking to me at least. So yeah. So we're going to talk about the AI tasks and how we can change the way we see AI with our vision, our philosophy of what the care unit is. So there's this task that we call named entity recognition. So the only thing you do is you take EHRs and then you label words. And why do you label words? Because it helps. It helps with coding, like what disease is the patient having. It helps with billing, like hospitals love this. And this has been on the market like for 20 years before you even heard the word AI. And it's because hospitals need it so they can charge patients, they love it. And then there's another task called summarization where you have like audio recorded summarizations, you transcribe the consultation into a lot of words, like every line is like every person. And then you summarize it into small snip or a small like chunk of text. And that's summarization. That's the task of summarization. And you have clinical summaries, right? People are trying to introduce this. I think at the Mayo Clinic, they're running a pilot according to multiple people. I don't know if this is confidential, but sorry. So and then classification. So then you have consultations, and then you wanna see how the consultations are going, if they're really, if shared decision making happens or if it doesn't. So you have these audio recordings, you have the acoustic data, the textual data, and then you just ask the model, hey, is shared decision making happening, yes or no, right? This is just a brief, so these are the like 3 out of the so many tasks in AI that exist, but this is what people are doing. They're using models, they're just doing this. How can we make this different so that it fits our purpose of caring? So the first thing, how can we transform AI to assist and augment care? So the first thing is mindset. And what I learned a lot about in the unit was few people listen. Few people take patients' agenda into consideration when they speak with patients, like doctors. So this is actually Nike's work with JP and I think Victor as well. But yeah, 7 out of 10 people did not elicit the patient's agenda during the consultation, did a project about this. So I was like, no. I mean, we're seeing the 7 people, right? But I've seen people who do care. I've seen at least one person who works consistently, and I would say is an extremely good doctor. So let's forget about the 7 people, and let's now see the 3 people. Let's see the 3 people that are caring. So that, what does that mean? Can we use them as an example to kind of magnify how care should be within the healthcare system? So this is a change of mindset of seeing, hey, this is a problem. No, there is a solution. There's at least one. So that's what we did. We're like, forget about the 7. Let's talk about the 3. 3 out of 10 people did elicit patient's agenda, and this optimism then is actually the driver for a lot of the projects that we're doing. There was one project where I remember, I think Victor was like, but nobody does it. Like nobody puts in the clinical records that the patient is going through burden. I'm like, but what if just one person does it in the last 10 years? Is that enough? Does it matter for that patient? Is it worth doing it for just that patient? We're gonna test it. But then that's the first thing that we have to change, our mindset. The second thing is the type of data. Usually research is, we have electronic health records. This is how it was in the past. And then we wanna see, for example, if the person feels lonely or if the person is, even if we wanna measure quality of life from electronic health records, we can do it. We can use AI, go through the records and see like even longitudinally measure quality of life. We can do it. That's been done. It's fine, but not really. Like we have to change the way we see data, because if we wanna care for people, we have to see what people are saying. We have to use encounter data. We cannot only trust what the doctor is writing on the notes. We have to see the person. And by seeing, I don't mean text. I mean speech also. I mean images. I mean really, we need to put everything into the model. Facial expressions, body gestures, how I move my hands. Am I feeling sad? Am I feeling low? Am I feeling happy? So we need to see it in that way so that we can put these 2 types of data into the models. So we are now changing the way we're doing AI models. We definitely need this type of data. If this data is not available, we need to collect it. But we are not just using electronic health records in all of our research, and we won't be doing it. Now let's talk about the modeling perspective. Okay, we spoke about there's a mindset, the type of data that we want to work with, and modeling. Well, we need the right theory. So we need models that actually work for this unique patient and not for people like this patient. And this is what Marlene said yesterday. And also whenever we think about the model, not only do we need like this approach, but also the right process of building the model, which we're gonna give it with an example right now. Then we need models that do not require human involvement. We need to avoid burden. We need to avoid spending so much money. And we want to implement models. We definitely need to make people be in the loop as much as possible. Is that possible? We think it is, but that requires more challenges. Explainable, we need to understand to improve the models. And then ethical AI models, we need to know how the models are working, whether they're ethical or not. They need to align with our values. And then we need definitely patient-centered outcomes. We cannot be measuring things that actually do not matter to patients. And sometimes that's so subjective that that's what it means, what matters to them. That's it. We don't need to define it more. Can we do that? Can we reach that moment? Like that the outcome is so subjective that it can be whatever they think is correct. It is challenging, but we think we can do it. So we're just gonna give you one example of how we can do this. And this is probably, this starts from the email that I sent to Victor and I was rejected. So this is, I'm sorry. No, so this is how to measure shared decision making. So the classical approach and our approach, there are two approaches. How can we measure shared decision making? So shared decision making can be measured from the classical approach. What is the classical approach? It's, we have 300 conversations. Imagine we transcribe all the conversations into text. We put into an AI model, you can call it whatever you want. We can put in an AI model, and then the model is gonna give us how to measure shared decision making, right? That's a classical approach. What is the problem with this? The problem with this is that you need people saying who actually had shared decision making, which conversations, in which conversation shared decision making happened. So you're gonna have people annotating and saying, oh, in these 100 conversations, shared decision making happened, and these other 200, it didn't happen. That's one thing. Then the other thing is like, you're doing the model for these 300 conversations. What about the 301? What about when you deploy it on the system? You're just capturing what's happening here. So this method is a method for patients like this, but not for the patient that you're gonna be seeing in your consultation. So this is a traditional method. It's useful. You can do AI model. You can change AI model with ChatGPT. I've seen so many people doing that. And you just put the text inside, and that's it. You have your paper, AI, great. We don't want to do that. Our approach is we need to avoid people annotating and saying who had shared decision making or not, which conversations, in which conversation shared decision making happened or not. So for that, we need transcript, which is a similar part. But what we did is let's put an intermediate step. So then we talked about we spoke about conversation alignment with some people from Edinburgh, and they say, yes, conversation alignment, I'll explain to you what that means, but this intermediate step makes sense because this is purely language. And then from these conversation alignment scores, then we do an associated with shared decision making. And then I'll explain to you how is this make sense very quickly, sorry. So what is conversation alignment? Conversation alignment happens, how many of you have copied like your partner's, friends, or working colleagues' expressions, like words, tones? How many of you have done that? All right, I mean, there are people who haven't. Really, I'm very surprised. But yeah, we tend to do that. It's totally automatic, and it's unconscious. You cannot control it, so you cannot manipulate it. It's part of dialogue. It's part of what happens in our brains. And before 1980, people used to think that dialogues were you emit an expression, the other person captures that expression through the brain, and then understands, and then that meets another patient. Very like dichotomous, very like a ping pong, right? That's not what happens. In 1980, that was totally debunked. And what happens is that as we speak, our models in our brain start to we build a model in our brain, and it starts to understand what the other person is saying, what I'm saying, and tries to align in a way so that we can have a mutual understanding. And when you start a conversation, you actually have a zero model. When you continue the conversation, they're like, okay, this is the topic, this is the way I should communicate. You change the tones, you change the way you express yourself, And this happens in an automated way. So we have no control over it. And this is expressed in copying another person's expressions, tones. Now that I work in the UK, sometimes I use UK words, British words, but this happens almost every day. So that's conversational alignment. So what happened is in 1980, I'm going to explain a little bit of what, I mean, we're going to definitely hear more on the workshops, but conversational alignment started with Pickering and Garrett. They started putting people like in very experimental rooms. One person was not in front of the other. They were in separate rooms, and there was always games. And they was like one had the maze solution. I mean, how to get out of the maze, whereas the other didn't. So one had to explain to the other how to get out of the maze. And they found that actually when they did the game, people start to copy each other's words and descriptions and the way they describe. They did the same thing with cards, also very controlled experiments, psycholinguistics, and they mirror each other's idiosyncratic descriptions. Then did the same with this other, they start to copy grammatical structure. So it happens across different levels of language. It happens from words, it can happen from tones, speech, and also body gestures. There's still research about this. So that means that, wow, the image looks very small, sorry. So this part here is very slow. But this part here looks like at the language, how language is aligning. That's the middle part. The bottom part is what the objective is. And the last part on the bottom, which is a situational model, is how our brains are started to kind of align or intersect in a way. This has also been associated with being empathetic. So people who align more are usually seen as more empathetic. Also in autistic children actually who have autism and could align is associated with better outcomes in trying to understand or understand language or understand the other person's feelings. So it's being studied quite a lot in other fields, but not in our healthcare field. So we thought that, okay, so if we put this model as an intermediate step, then what we can measure probably is alignment. So what does that mean? If we train a model to understand language agnostically, then it can identify alignment because people can copy each other's discourse styles. People can copy each other's styles throughout the conversation. And that's what we did. We did agnostically, let's train the model. It understands when two people are having an alignment in discourse. And then when that happens, then we say, okay, there's alignment. Now is this score associated with SDM? And then we found that it is associated with SDM. Not completely, and then many more questions came after that. What comes first? Conversational alignment, shared decision making. Do we need to actually study conversational alignment in healthcare settings, which hasn't been done from a qualitative perspective? But those are the things that we're going to be speaking later on the workshops. So yeah, we thought this is the right theory because it's agnostic to the person. We can deploy the model and it can be deployed for any patient and he's gonna find who's having an alignment because it's agnostic. It's just based on language. And then we don't need annotations. We just deploy it to the system and whoever aligns, if we continue finding that it is associated with SDM, then that will be the right thing. Okay, so no human involvement, explainable, ethical AI model. So we're going to talk about that tomorrow, why this is ethical. Patient-centered outcomes is quite easy to pinpoint that this is SDM outcome. But what are we doing next? So the future is not only using textual data, but also using acoustic and visual data. And we're working on that to try to measure shared decision making. But then the other Victor was like, why don't you just do it like right away, like more efficient? The other Victor, I mean, Victor's son. So now I was like, okay, so I have now the other Victor telling me that the way I'm thinking is too complicated. So now the other Victor is telling me I'm too outside the box. And And that's a Montori course, yeah, that he's not wrong. He's right. Like we should definitely test this. We should definitely test whether each modality can actually detect alignment, and that can be used to measure shared decision making. So what comes next? Well, implementation. We also have to, after it works, then we have to do comparative effectiveness research, and then the other work is how to integrate this into healthcare systems. So AI can be transformed to fit the purpose of care. And sometimes, as you're going to see with other examples, with Curly, Felipe, and Misk, you're going to see other examples where we had to redefine what the task is. For example, summarization, we had to redefine it to patient-centered summarization because the way it is defined is wrong. It does not make sense. But yeah, we'll see that on the workshops.
Well, I will invite the speakers to the front chairs. And David, and I think we only have about 70 minutes for questions. Any questions from the audience?
Just need to get mics circulating.
So I think Natalie has the first question. And if our virtual friends, they have a questions, please put it in the chat and we will try to get those ones too.
Hello. Thank you very much for the presentation. I think it's very interesting, and I don't think you are thinking that far out, like that outside the box. I think it's a matter of how we see our creation of knowledge, aka epistemology. And I was thinking about the fact that right now the way that we are thinking or using AI. Oh, sorry. The way that we are thinking and using AI right now, what I heard is more of a positivist way. So it's more of the tendency that we have to to follow the biomedical model, right? Health disease solutions. But what I wonder, especially from your model, Oscar, is that it's very interesting, but I wonder how are we going to extrapolate this AI construction to other ways to create knowledge, like constructivism in the way, which is the moment in we work with somebody else, in this case, maybe our patient partner, or our own patient in clinic. So how do we give them a space to really contribute? Or even if we go further, we have these movements of postmodernism in which we have to deconstruct everything that we know to create a new thing. And I could keep like extending myself in other ways. So how can we grab AI to really go outside the box, even though it's already starting to go outside the box in an ethical way that can be for tomorrow?
So it seems that, but the microphone is being passed to you.
What do you mean by, you mean like building research hypotheses, like doing AI for research hypotheses?
So, like, yes, but like the positive vision, what we do is straightforward: to create knowledge, to represent an experience or a phenomenon, and we say, okay, this is what's happening, my encounter, this is my reality of what I see. And normally we tend to publish it and sometimes read it in a way that we take it as a reality. But it doesn't really represent everybody. If we think about Care That Fits from Merlin, we can do a paper that can be working in a specific population or community, but it does not really represent everybody. So how can this technique can be used to kind of modify this loop? So even if we use AI, eventually there is a risk to fall in what the decision aids are falling. We are trying to classify everybody so the decision aid is going to be useful. How are we going to work so we don't get again back in the same loop and maybe use AI as a resource that is going to be again being repetitive and not really feeding everybody?
Yeah, I think so. The example here is, for example, imagine we implement this in a healthcare system. You wouldn't see it. So it's not really gonna disrupt anything. So it should just be a normal conversation. It's not a tool that people are gonna be like on the computer. It's just a thing that you put in the middle, so it's going to be video recording and that's it. Unless, of course, patients doesn't like it. Patients don't like it. There are also other examples from Misk and Felipe where you also not going to be seeing anything. So the only thing that you're going to see is things, as JP said, we're going to try to take things outside, like out of the encounter. We're going to try to take tools out of the encounter. We're going to try to take other things out of the encounter so that the only things that is left are just the doctor and the patient. So I think we're going that way. But I mean, because we're not using tools. Is that, sorry, I don't know if that answered your question.
Thank
To
you.
some extent, I think what, I'm going to try to paraphrase, but there is a reproduction of what we do and what we know as the technology comes in versus allowing the technology to change the way we do. And so not only transforming AI for care, but how is AI going to transform the kinds of questions that we're ready to ask and the kinds of ways in which we're going to find those answers, right? And so, and there's a number of theoretical and philosophical points of view about how knowledge is constructed that is not completely encompassed by the scientific method. And so the question, I think, is, are there ways of knowing that can be now facilitated by this technology that we're not thinking yet about?
Thank you.
Very good. Mike has a question in the chat, but I think you already answered how the measurement of SDM might lead to improvements in care than fit. But I think you already touched on that a bit. Yes, question.
Thanks for all these great presentations. I'm particularly concerned about AI leading us down a bad path of diagnostic momentum. And how do we avoid, the power of, yes, getting to the Graves' disease diagnoses, but then allowing space for really exploring what the other possibilities are. So diagnostic momentum is already a huge problem and leading to a lot of diagnostic errors. So A, how do we make sure we don't fall into the pit of diagnostic momentum? And that ties back to Oscar, to your comments about conversational alignment. And I'm intrigued by that concept. I'm a little bit skeptical, and I wonder if there's any research about gender differences in conversational alignment. And I'll just use the example of, I've been working on conversational alignment for 36 years with my husband. And and if I say, let's go to Paris in January, and he says, that sounds like a good idea, I make the reservation to go to Paris in January. And he's like, what are you doing? I thought it was a great idea, but I didn't know we were taking action. I can't imagine AI is going to decipher between the nuances of what we think we said and what other people heard. So two things, and I think they're related, is conversational alignment leading us to diagnostic momentum.
So perhaps Nike, you want to take the first one?
Yeah, so I think in like, I had that picture of the diagnostic process and how AI can potentially help that pathway. I think the importance for us was then to understand that kind of like that structure of the diagnostic process in the clinical encounter, because we need to kind of like understand how the process happens today to then see how the AI solutions are going to be introduced either before or after. The other part there is there are like multiple things that you can use to kind of like automate or give you a differential diagnosis of possible things that are happening. But this, I think, falls a little bit more into the fact that before the AI solutions are deployed, we have to make sure that they are accurate and they are safe. So we haven't talked so much about the development part of the AI solutions, but they have to be kind of like focused on fixing an important problem, in this case, diagnostic errors. And then you have to see how you're going to implement it so that they actually not lead to more harm. So that all goes into that space. So from my perspective, I think understanding how the diagnostic process happens, so things that were happening before the visit, then at the visit and afterwards, that's why we kind of like engage in that process. So then now it's easier to say, okay, if we're going to have a tool that you give the symptoms and gives a potential diagnosis, and it's trained to always give a diagnosis, instead, even if it's the most likely, so it has that uncertainty and those probabilities. How that is actually used in practice is like a second question. So it's kind of like in that development pathway, just first making sure that the tool is doing what it's supposed to do without unintended consequences, and then introducing it into practice, not only so that it's not disruptive, but that actually it leads to improve care. And most of the AI solutions are like in the first step, just making sure they work. So all that other work is to be done.
Yeah, the conversational alignment thing. So I think, yes, you're right. Like there's so many nuances. And I think that's why we wanna increase that into more features like speech, how we sound, and also how we move. And then whether that there's some alignment there. And then when we did the study, it was discourse alignment. So it means it's like how a sentence is reproduced. Whereas there can be alignment in semantics, there can be alignment in syntax, how the words are organized, or morphology even. So I think there are these other things that we will also love to explore. We just need more people helping us and money.
A brief question from the chat. Lucy, I think, is asking, and this is mostly about the modalities of encounter data, particularly the video modality that might be able to capture even facial expressions. And the question is, what would be the role of something like that in healthcare, for instance, recognizing facial expressions and emotions? Yeah, you do.
Yeah. So yeah, then the question is, can you put that model into the robot, right? And can the robot speak to you in an aligned way? So then you created a conversational alignment model, and actually it's good at kind of understanding when two people are aligning. But can you put it in the robot, and then can the robot see what you're saying and then align with you because it already knows what alignment is? I think we're very far from it, to be honest. I think there can be, I see robots. I'm a little bit pessimistic in that side. I see robots being used for other things, like very procedural stuff, like measuring cognitive impairment. So you have a robot there, you can measure cognitive impairment. I think conversing with you is more, it's so nuanced as you mentioned, that I don't see it happening at the moment. I think there's so many hallucinations too. There's a paper JP sent me, which was about we just have to get used to hallucinations. Hallucinations is when a model says things that do not make sense. So the model starts saying, "Hey, how are you?" Imagine talking to you, "Hey, how are you? Yesterday, and then yesterday I saw a soccer match, and this team won." And then it's not continuing the conversation. And yeah, so it's so prevalent hallucination. That's why I don't think we're there. The models that we have right now are also not there. So I think we still have we need a lot of time for that to happen.
Thank you, Oscar. Victor has Camila.
So I understood that we're feeding the model with the data we're collecting from the encounters. And I wonder if there's any concern with the diversity of this data so that the machine can recognize different type of population and reduce a selection bias or something like that. Does that make sense?
Yeah. David, do you want to do that?
Yeah, absolutely. So to give you kind of an answer to what you're saying, and to touch a little bit on previous questions, I just want to emphasize that these artificial intelligence tools that we have right now, they can only do what we train them to do. It's not like they're training themselves. It's not like they're deciding what they're being asked to do. They can only do what we train them to do. And that's why I think having these sort of conversations in which we are at the center of what these systems should be doing is very important. Because right now it's very heavily reliant on data scientists and PhDs that are doing the coding part. But I don't think there's enough multidisciplinary teams that are working together with doctors, with patients, with all the stakeholders that are involved in the encounter. So I think that's our responsibility, because the way things are going, we are going to have to redefine the role of the physician. We are going to redefine the way we interact with these tools. I don't think they're going to replace us, but I do think they're going to replace the way we provide care. And we were having an interesting discussion just last week. These models, they don't care. They're just that, mathematics. but you as a provider, you care. And you can use this model to improve the care that you are providing to your patient. So I don't think you're going to be replaced, but there's definitely an opportunity to make things better, and we need to be at the center of it. I think that's the first kind of a statement I wanted to make. And to go specifically to your question, again, it's only going to be as good as the information you're putting into the model. So the more diversity you can build into the system, the better. And there's a lot of people actually working on how to identify bias within those systems. Because if you create a system that inherently was trained on data that is biased, whatever you get from it is going to be biased, right? So using diversity in the data sets that you're using to train these solutions, it's key, but also building safeguards that can identify when bias is happening. And there's a lot of work in that area. And that's one of the reasons why I think, again, this is not a mature technology. And this is something that we often forget, but look at absolutely any artificial intelligence solution. There's always going to be a little asterisk, very small text that says this is an experimental technology. This is a process that is in the works.
So I'm just gonna, I'm not stealing, Maggie's got the question, but I think more of her point is also that the selection bias is in the fact that it's those who interact with the healthcare system, right? So what we're designing, what we're talking about is all predicated on the fact that people interact with us and come into healthcare. And as I think of a lot of us in rural healthcare, I mean, that is a huge subset of our population that don't have access to healthcare, don't come into healthcare, and we're missing all of that. So again, I think that as you guys imagine this and think about this, we're missing that group. So how do you design, implement, or look at AI based on those who maybe don't directly interact with us, but still their health, their well-being, their care that they need is just as important. So,
Yes, last question.
Okay. I had, one thought, actually, David, when you were presenting and you had the kind of loop of learning, it reminded me a little bit of the visual from your presentation this morning, Dr. DeKoenig, around the loops and how it's led to some de-skilling amongst people who are managing their diabetes. And so I think it's interesting to think about those loops and what are they leading to de-skilling versus reskilling, upskilling, teaching people new things. And it made me think when you presented, JP, your kind of 3 things of care assisting, care augmenting, care replacing, and they kind of moved up. I'm sure probably in complexity, but I was thinking in purpose, I would have put them exactly opposite, because care replacing to me means we're continuing the reduction of healthcare to transactional, and then we're training a robot to be able to do something that's transactional. But the idea of care assisting made me think of things like, if as a physician, before you went into the room, you were able to ask AI, what are the biases I should be thinking about as I go into this visit? What are the things about that we know about this patient that might be, common biases you have? Or even for patients, I think about how many stories I've heard of. I've talked to 4 different doctors. All of them seem to kind of Sheila's point around diagnostic momentum. All of them prioritize my mental health issues from 5 years ago, which I don't think are connected to this. What do I share with them? What do I tell them? How could I begin to frame what's going on with me in a way that maybe would reduce the likelihood that they would diminish those things? So I think when thinking about the data sets, I think it's also about the purpose. And I can understand, of course, why we train it on things that we know the answer to, because that's how we know if it's working. But I think the purpose of care requires also moving into another space in terms of the types of questions we ask, and not having to need it to have answers that we could have predicted before.
Thank you. Very good. Thank you, everyone. Appreciate it. Thank you, the panelists.